my name is Nancy Teixeira. I'm a registered nurse. I'm from Milford, Connecticut, which is right on the shoreline, Long Island Sound. I flew in from Hartford today, where we actually finally, I think spring has sprung in New England. I'm the administrator for Wren Laboratories, and you'll see the presentation on our new molecular biomarker called the NETest. My background is traditionally critical care, operating room, trauma, and nursing management. I was contacted last spring by Dr. Moblin. He was looking for a nurse to come manage his lab who has a working knowledge of carcinoid cancer, who knows how to speak to physicians and family members and patients, when suddenly my name popped into his head. So he called me up and he asked me if I wanted a new job, and I said, sure, why not? I'll give it a go. I am a carcinoid patient. I've been living with the disease, not dying from it, for 18 years. My primary was ileal. I went through the resection. I was told I had a surgical cure, and then 6 years later, they found 4 lesions in my liver. I had a bland hepatic embolization, and since then my lesions have not metastasized. They have not grown. I do have syndrome, so I take Sandostatin 30 every 21 days instead of 28 to abate my symptoms. But I have a really good quality of life just doing that alone. So with that being said, please raise your hand at any time if you have a question for me. I have business cards I'll give out to anybody who's interested. If you're interested in getting a copy of the PowerPoint, you can just shoot me an email and just say, you know, it's from the Northwoods group, please send me a copy of the PowerPoint, and whatever other information you might want, just shoot me an email or call me, whatever works for you guys. Journals with Dr. Moblin, and Danielle and Steve are our 2 scientists that actually do the tests, run the assays for us. Okay, welcome and thank you for your time and for allowing me again to come and visit with you. So most people, you'll have to forgive me because I've traveled all over the country with my presentation, and I don't know the level of understanding in the group because I don't know everybody, but I frequently have people who are newly diagnosed, and then I have folks who've been diagnosed for many, many years and are quite knowledgeable about the disease. So it's kind of basic at front. I apologize. I don't mean to insult anybody or offend anybody, but it just gives us the basics on what carcinoid is and where it all started. So carcinoid cancer was first discovered in 1907 by Siegfried Obendorfer. And he really didn't do us any favor because he called it carcinoma-like. And even to this day, there are oncologists and physicians out there who will tell people, well, it's not a real cancer. Well, if it's not a real cancer, how did it get from my ileum into my liver? But unfortunately, they're going by the old school with what Siegfried did for us. Tumors of the small intestine that are known as NETs. And again, I know there's probably people with lung, with pancreatic, so this presentation bounces around all the neuroendocrine diseases. And regardless of primary site, the NETest, if you have a neuroendocrine disease, whether it's pancreas, whether it's lung, whether it's intestine, whether it's gut, the NETest is still appropriate for your situation. And as we go along, you'll see what I'm talking about. So about 12,000 individuals are diagnosed with NETs each year in the United States. A large portion of the patients that are diagnosed, 50% are already present with metastatic disease because it's so indolent, it just gets missed. So by the time it's found, you've already got it in your liver. The clinical symptoms of the syndrome arise from functioning tumor that has metastasized to the liver and dumps the serotonin right into the hepatic circulatory system, and that's what causes the flushing, the diarrhea. Not all patients have symptoms. And some of the symptoms, as we all know full well in this room, are confused with other diseases such as irritable bowel syndrome, menopause, inflammatory arthritis, things of that nature. So the tumor biology is serotonin is a vasoactive peptide. It's the most biologically active substance that's secreted from the carcinoid tumors, from the active tumors. So we have two types: functioning, that's clinically active with symptoms, and non-functioning, which are silent. Okay, once the tumors spread to the liver, as I said, they bypass the hepatic filtering system and they enter directly into our circulation. And this dumping of serotonin is what causes the symptoms to ensue. And we're all familiar with, maybe not all of us, because I have met quite a few folks who've never experienced any symptoms at all. Flushing, diarrhea, cramping. Telangiectasia are little red bursts, blotches on your skin. Wheezing, arthritis, pellagra is more skin staining. Right heart valve lesions, usually the tricuspid valve or the pulmonic valve, and peripheral edema. That's why every 5 years, if you are experiencing carcinoid syndrome, you should have an echocardiogram done to monitor the right side of your heart, your tricuspid valve, and your pulmonic. And then there's carcinoid crisis, which is a severe life-threatening event that is usually precipitated by general anesthesia, initiation of chemo, as well as manipulation of the tumor or the tissue as when they're removing it during surgery. So it really is, I'm not afraid to have surgery, I'm afraid of the anesthesia. It involves profound hypotension, which is a drop in your blood pressure, and then a rebound effect to high blood pressure, hypertension. And then the central nervous system changes can lead to coma or death. So you literally go into a coma from the blood pressure suddenly dropping and then suddenly going up. So how is it diagnosed? It's based on the following: clinical symptoms, hormone levels, radiological and nuclear imaging, histology or pathology, as most people know it. So the biochemical markers that we use, one of them is the urine 5-HIAA. It's serotonin metabolite that's found in the urine, as most of you know. You do a 24-hour collection, which is always fun. Used to get me a free seat on the train. Nobody wanted to sit next to me with my big jug. The only caution with this is that you get a lot of false positive negatives because it is affected by intake of certain foods. And you might forget and have something to eat during that 24-hour time period, and then boom, you get an unreliable value back. The Chi-67, when I was in Barcelona in March, at the European Neuroendocrine Society, this is where all the leaders around the world get together and they argue what's good, what's bad, what's current, what's not. The Chi-67 was really under a lot of controversy. And half the room said, no, it's no longer a good marker. Others were like, no, I still use it because it's all that we've had so far. So they just go with it because it's what they have. But it's a protein that's found in the cell nucleus during cell division, and it's a marker of tumor proliferation. A low Chi-67, which it's measured in percentage, so if it's less than 2%, they say that you have a greater chance of a prolonged survival. The only problem is that this test, the performance of it varies from lab to lab and technician to technician, because what they do is, when they look for these proteins floating around in the cell, they eyeball it under a microscope. So eyeballing to one person is different from eyeballing for another person, let alone from technician to technician and lab to lab. So this is the big controversy. A lot of the physicians were saying, it's just not specific enough. It's too helter-skelter. And then there's CGA and pancreastatin, which is an offshoot of chromagranin. It's present in neuroendocrine cells. It's obtained by blood work to determine its levels. CGA levels are nonspecific and can be elevated due to unrelated conditions or not elevated in patients confirmed with having NETs. Patients taking PPIs, omeprazole, or with liver disease can have falsely elevated levels. So 18 years I've been living with this disease, and 18 years I've had negative 5 HIAAs and normal limit CGAs. There's imaging that we have to go through. There's the PET scan. So the latest one is the gallium-68, which I'm sure all of you, probably most of you in this room have heard about. There's varying forms of it, the DOTA-TOC, DOTA-TATE, DOTA-NOC. It all depends on the receptors that they've identified that are specific for your tumor, which one of these you would get. It has a higher sensitivity and it's easier to perform than the OptiScan. It's offered only at specialized centers. Right now in the United States, I think it's offered maybe at 4 different places. I know Louisiana's going to start, but they're not going to be starting until probably the fall. Iowa has it, Indiana has it. They were doing it at Vanderbilt, they're no longer doing it there. NIH has it, and I think Stanford has it out in California on the West Coast. So, and these, it's in its early infant stages in the United States. Most of these centers, even, they might have started doing them a year ago and they've only done maybe 10. So that's something to take in consideration. Right now, I believe you have to apply to become part of their trial in order to be able to get this done. And I know the Connecticut group leader, Pat, she went to Iowa and she actually had hers covered by her insurance. But she saw Dr. Odorizio out there.
The G68 in Iowa, they just cover it, but you have to pay for the Pancreastatin.
Oh, I see. Okay. Yeah, she didn't tell me that. Okay. So they do an Pancreastatin and the gallium-68?
So
I went to Germany 2 years ago for my first one. I'm going to Milan next Sunday for my second one. It's been 2 years.
That's the 68 gallium, that's that radiology?
Yes, it's radioactive. Yeah, it's radioactive nuclei. Yeah. Yeah. So there's somatostatin receptor scintigraphy, which is the Octreoscan, as you all know. It's an MRI with a CT scan, and you get injected with either octreotide or lanreotide. And they bind to the 2 most prevalent somatostatin receptors that are found in neuroendocrine. So that's how things light up, so to speak, when they tell you. I love that when they go, anything light up? I said, no, but you will tonight. I used to tell my kids I was going to be the night light. Okay, is there any other way of monitoring disease progression? And disease progression is the key here. Keep in mind, CGA is used to measure the secretory action of tumors that have already formed. So CGA tells us how active the tumors are secreting serotonin into your bloodstream. CGA, it's yet to be proven, there's no data, there's no literature yet to confirm that, that sandostatin, which calms the tumors down, it lowers that secretory action. That's how it helps our symptoms, because it keeps that serotonin kind of at peace with the tumors. But sandostatin has not been proven to shrink tumors or prevent metastatic disease. So right now it's currently being used only for those individuals who have symptoms and need to have relief from those symptoms by having the serotonin put to sleep, having those tumors put to sleep. So, yes, there is a way to follow the progression of your disease, and that's our test, the NETest. And it's a blood multi-gene transcript signature. So we actually found 51 genes that are specific to neuroendocrine tumors. We found the signature of neuroendocrine tumors. And they utilize it's polymerase chain reaction, the PCR. That's the type of test that they do in the lab in order to identify those specific genes. So how does it work? It detects circulating neuroendocrine cells in the bloodstream at a molecular level. So you're told you have a surgical cure. Okay, 2 years go by, you're still feeling good, but you know what? You want to keep track of your disease, so you have the NETest done. The scale of the score is from 0 to 8. 0 meaning you're clean. There isn't anything circulating around. 8 meaning you have a Maserati, something's going on. It's there and it's circulating. Okay, so that's the level. The beauty of this test is it's not just in one number. It's having a series of it done. Okay, so you may find two years post-op you have a test done and your level is a 2, which really is it's very low activity. Then you decide, I'm going to do this again next year just to make sure it isn't acting up. Now it's a 4. Well, now we've seen an increase. Now it's trending. So we may not suggest that you go another year. We may say, you know what, you've gone up in the past year, come back in 6 months. Well, if it's a 5 or a 6, now we know it's starting to take off, and we can tell you that you're having activity long before a tumor even shows up on imaging, before these cells clump together and form a tumor, because we have found them in their early state while they're still circulating through your bloodstream. Does that make sense to everybody? So that's why we call it molecular, because, you know, and I feel bad for these surgeons because they'll call us up and they'll say, but he had clean margins. Well, I'm an old OR nurse, I'm just an old nurse in general, but you know, you cannot see something at a molecular level when you're in the operating room. You can see gross tumor, and even the pathologist can tell you clean margins, but they cannot detect these cells at the level that we find them in the bloodstream. So this is it. It's a molecular diagnostic that provides highly sensitive and specific information with respect to tumor status and therapeutic efficacy. So we've had folks come to us, send us their blood, they get a baseline level, and then they go off to Europe and have PRRT done. Okay? Then they come back and they send us another sample. They want to see if that PRRT is working. Or we have people who have done chemotherapy, or they've had surgery. Some of our folks, they've come to us just newly diagnosed, they haven't had their surgery yet. We draw a baseline, they have their surgery, they'll come in high, they might be like a 5 or a 6. 3 months after surgery, they'll come back, boom, they drop down to a 3 or a 4 because all that they've had a lot of tumor burden removed. So we do expect to see that number drop. So the test not only tells you the presence of the neuroendocrine cells within your bloodstream and how fast they're moving, whether you have a Volkswagen or whether you have a Maserati, but it'll also tell you whether or not your therapy that you're undergoing is working. Because if your therapy is working, then your level should be, boom, straight like that. Okay, it provides an individualized view of your tumor because we're looking at your blood, your cells. It's been developed and validated in over 600 neuroendocrine patients. So here's the role. So first, when you come into the world of neuroendocrine after you've been diagnosed, you need to define it. What's your primary? Do you have METs? Where's the METs? What grade and what stage is your disease at? Then we go on to our treatment options. Usually surgery is still the guiding light of treatment. Get rid of that primary tumor. Some folks go through ablation. Some people use biologics, different drugs, chemoablation, and others will go through the PRRT, which is the radionuclide testing that they do out in Sweden. Dr. Oberg's doing it out in Sweden, and they're also doing it in Germany. Then you need to assess the efficacy of the treatments. So you have the NETest drawn, you go for imaging, and then we check your clinical status. How are you feeling? I mean, a lot of times I'll call people up, I get their test results, and I'll give them their results, and I'll just say, well, how are you feeling? If you're feeling good, then, wait, and let's get another test in 3 months and see where that's going. You might have just had an off day when you came in here, gave us your blood. So the NETest optimizes identification of disease status and usage of the most effective therapy. And that's the bottom line. That's what we're looking for. We're looking for quality of life. We all know there aren't a whole lot of therapies out there for this type of disease that people can offer us. So when we do pick and choose to do something and commit ourselves to it, we want to know if it's working. And the NETest can tell you whether or not the therapy that you've chosen is actually working. This is what a report looks like, a test result. So this is what I was talking about. You come in, you have test 1, there's your baseline level. So this one is a 4, and it's low activity. Then you come in, wow, now you've got a level decrease. You're down to about a 2 for a second one, which is good. Sometimes we'll see this again when people come in preoperatively, they have the tumor taken out, then they come back and we see a drop. But then they come back 6 months later and now there's an increase. And so we say, whoa, what's going on here? Now we need to get re-imaging done to see if there's new tumor that's formed. We need to do another health history on you to see if there's any changes in your therapies and in your lifestyle. So Dr. Kidd put this together just to let, because a lot of people, and rightly so, you want to know how has this test been validated? You know, how do you know it works? So for testing and validation of the NETest, we did a study in over 200 NET patients. To study the reproducibility, a test is not valid if you cannot reproduce it. Greater than 150 NET patients, and for the effectiveness for therapy, greater than 200 patients. And then we evaluated its performance against CGA. We would draw a NETest and run a CGA on folks to see which one was more accurate and specific, and ended up being the NETest. We did that on over 150 patients. So here's the comparison. You can see across the top. The NETest is in red. That's an excellent biomarker performance. Whereas you can see CGA and pancreastatin, they don't quite get there. But you know what? That's all we've had. That's all that's been around for the last 30 or 40 years. And that's why docs continue to order it. But what we're presenting now is it's cutting edge. It's time to move on. It's time to offer the neuroendocrine community something more accurate and more useful in managing the disease. And the NETest does that. So it's a highly accurate biomarker, greater than 90%, and outperforms CGA and pancreastatin. So what does this mean to you as a patient? Well, first of all, it identifies that you still have the disease. Because some people say, gee, I had the surgery, now it's come back. Well, it never really left, unfortunately. You know, you think once the tumor's out, then it's gone, but it's not. It's still there at a molecular level. Again, if the disease has been removed, is there residual disease? This test will tell you that. If it's been treated, is the therapy working? If it's considered cure, it'll confirm the absence of residual tumor or residual cells that will eventually form into a tumor. And if you have symptoms, it'll identify it if they're due to the NET disease. This speaks to a lot of the support groups across the country. I've had various individuals, almost one from every support group, who has not been definitively diagnosed. They call me up and they'll tell me, and they'll read me all the signs and symptoms of carcinoid syndrome. And they'll swear that they have carcinoid, but they've gone through a gajillion tests and no one can find the tumor. And then they come to us, and then we'll draw their blood. And every now and then we will find somebody and say, yeah, it's there. It's just a matter of finding where your primary tumor is. And we have not yet been able to do that with this test. We hope to.
So you don't, with the ability to identify 51 discrete genetic markers, you can't tell.
Not the location, not yet.
Location.
Not yet.
Okay, so this just says you got it, but that's it.
It won't tell you where the primary is, no. But that's in the works. It's like taking steps. We found it, we found the signature, okay, now where's it coming from? And we hope to get there soon.
So you're saying that any of the NET tumors are going to produce things that always read no matter.
We've identified the genes specific for all, yeah, the neuroendocrine, whether it's pancreatic, lung, these genes are the common signature.
Okay. Thank you.
Yep, that's a good question. So unlike CGA, the NETest is not altered by PPIs, food, antihypertensive medication, or age. Unlike pancreastatin, the NETest is not increased by pancreas, kidney, or liver damage. So the clinical advantage of the NETest. It's a simple blood test. They say non-invasive, but yeah, we have to stick you in the arm to draw 5 milliliters of blood. I think that's invasive, but you can tell a scientist did this slide. There are no dietary restrictions, no fasting, none of that. It's easily accessible. Well, we'd like to think we're easily accessible, but as I travel around the country, that's not as necessarily the case. And we can detect NET, METs, or tumor regrowth prior to the tumor even showing up on imaging. It assesses the efficacy of your current treatments for optimal disease management and for quality of life, because that's what we're all after. We know there's no cure, but in the meantime, that doesn't mean we can't have a quality of life while we're searching for the cure. How it can change your treatment. So there's 4 interpretations that enable consideration for changing the management strategy. So if you have normal values, 4 values are stable, the disease is cured, or it's non-net disease. We suggest people come in for a follow-up if that's the case, a year later. If you have abnormal values, if you have 4 values and there's no change, then you're stable. So if you come in at the highest, say you're at a 5 or a 6 on the scale of 0 to 8, but your symptoms aren't changing and you're consistently a 5 and a 6, you have stable disease. So we're not going to get you all worried about that. If you have a decrease in 4 values, then the treatment's being effective. And keep what you're doing. Keep on taking what you're taking, keep on doing what you're doing. If you have an increase in 4 values, sequential values, then something's going on. Your treatment isn't working, and you need to reassess your situation. So we've presented this. We've been busy bees traveling around the world presenting this. These are some of the articles and some of the meetings that we've presented at. Last September we were at NETS. And then the Carcinoid Cancer Foundation, I'm a former board member, Dr. Warner's group. They had 10 highlights for the year in December for 2013 of advances made in the neuroendocrine community, and we got number 5. We were listed under genomic studies and molecular profiling. So we're really proud of that, being recognized for being pioneers and advocating for neuroendocrine population. So how do you access it? So if you want information, you want to schedule a test or send blood, and I'll go into more details. You contact me, that's me. I'm the administrator, I'm in Connecticut. And we have a brand new website. So I encourage you to go on it, because this is on the website. There's a lot of information on the website. If you want a copy of this in a Word format, so it's easy to download, I'll give you my business card. Shoot me an email. I'll be happy to send you whatever information you'd like. We're very transparent. We have nothing to hide. If you want scientific articles, then I'm going to suggest you go to the website. Because on the website, we have full PDF text of all of the professional journals that Dr. Moblin, Dr. Kidd, myself, we've been published in with respect to the NETest. So I encourage you to, again, the carcinoid community is a little bit smarter than the average bear. So some of these scientific articles can be kind of overwhelming, but I find for the most part, most carcinoid patients do understand it, and they get through it quite well. And here are just a list of some of them that we've published. Dr. Moblin did present at the European Neuroendocrine Society in March in Barcelona. We had a very good reception there. And now I'll take questions.
So if the oncologist says we're going to do a blood test and wants to read CGA and pancreastatin, what's he going to know from that your test can't get it?
Okay, so...
Those are going to measure function.
Right, they measure function. Ours does not measure function of tumors that are already there. Ours measures the presence of neuroendocrine cells and how quickly they're circulating through your bloodstream.
So it's diagnostic, the NETest.
It is diagnostic. There's a couple of caveats I'll give you though. We have found people with inflammatory bowel disease, Crohn's, celiac, they come out high. But when you think about it, their gut is sloughing off healthy tissue because it's ulcerated. So it's sloughing off tissue, and then it's trying to make new healthy tissue, which is what happens in a cancer situation. So I asked Dr. Kidd, I said, why are we getting all these, you know, not all of them, but the few people that have shown up they have not been definitively diagnosed, but they do report a history of having bowel issues. He says they just have a bad bowel. Neuroendocrine cells are present in everybody's body. Every human being that's born has neuroendocrine cells. But then there's the lucky few of us, these cells then morph into and go crazy and turn into carcinoid or into a lung net.
Yeah, now, I see Dr. Odorizio, and I'll be seeing him at the end of the month. Can he contact you and get the tests? Or
Yeah, I've spoken to Dr. Odorizio at length. I spoke to him this past fall.
Oh.
You know, he's been very, very good. We've been referring some folks out to see him to get the gallium scan done. The issue, and that's a good point, the issue with access is getting somebody to draw your blood. Now, we've had folks take trips up from Virginia and Pennsylvania. You know, they're on the East Coast. And they've come up to our office to have the blood done because they just can't find anybody to draw their blood. If your doctor says they're a neuroendocrine specialist, they know about this test. They know about Dr. Moblin, they know the literature, they know the study, they know the science behind it. If your oncologist says, I don't know anything about this test, and claims to be a neuroendocrine specialist, they're not a neuroendocrine specialist. I'll tell you right up front. Because we have been in every single publication, both oncology, we've been in Lancet. I mean, say they've never heard of it, then they're not keeping abreast of what's going on with your disease. I hate to say that, but it's the truth. And we're all consumers in this room. So Dr. Odorizio is aware. He knows the protocol. Anybody who's interested in sending us a sample,
Can they
can draw your blood, and it has to
be.
be shipped on dry ice to our lab, because our lab in Connecticut, we're the only ones doing this test in the United States.
But he can get it done.
He can, if he chooses to, yes, he can draw your blood, put it on dry ice and send it to us.
Okay.
How are they receiving it? Are they doing it?
You know, it's kind of weird. The guys in the United States are kind of like, oh, you know, let's wait and see. Let's give it more time. Let's see if there's more numbers. Let's see more outcomes. The guys in Europe are like, this is unbelievable. It's about time somebody cracked the code, and you finally did it. So, and that's a great question, because at least at this point, we're getting over 200 samples a week. We get it from Poland. We got 40 from Poland last week, 200 from Milan, from the Institute of Cancer out there. Dr. Oberg has just joined in with us. He has sent us 60 samples. So every month, we're getting, in Germany, Bad Berka, they're sending us samples. So our volumes, this is why I had to stop bringing the scientists with me to draw bloods. Early on last fall, we actually had our little, you know, we had our machine, our cycler and centrifuge, and we were going through airports with it, and we were going to groups, and we were all drawing bloods and running the blood down, freezing it on dry ice, and then shipping it back to us in Connecticut. I can't take them out of the lab anymore because our volumes have shot up because of the European groups that have joined on board. The guys in the United States, I've met just about every leader in the United States, and you know, at the meetings, they're excited about it. They see the merit in it, they see the value in it, but as soon as a patient goes to them and says, well, will you draw my blood and ship it off to, oh, well, I want to see some more. Now, and I'll be honest with you, and this isn't anything, I'm not speaking out of turn, but you know, for years and years, CGA was the only game in town. And it's a totally different test. But there are individuals who are fearful that this is going to replace CGA, you know. But there are individuals who have financial foundations in labs that do CGAs. So it doesn't behoove them if the NETest comes around and the CGA ordering starts to drop off. They lose out financially. And that's the real world. I mean, it's like that anywhere you go in medicine. And when there's new tests and innovative things, there's always that competition going on. So I don't know if I answered your question. You know, there's some guys in the States that back us up 100%. There are other guys that are kind of, you know, Dr. Warner sends us samples all the time. He's behind it. He knows the science. The guy's 88 years old, but he's been around this for years. And he says, my God, it's about time somebody did something. But, you know, he's out of Mount Sinai. Hold on one second. Go ahead.
I'm wondering, I might be confused here, what is the benefit of the NET test if you already know you have carcinoid?
Okay, so it'll tell you if the current therapies that you're undertaking, if they're working, or if the disease is starting to act up and take off. If you can expect to have further metastasis. Does that
What
make
if you
sense?
already know that?
What's that?
What if you already know that?
If you already know how your disease is going to progress?
Well, I know that it's on fire right now.
Okay. And so what you would do is sit down with your doctor, come up with a plan for therapy. How are they going to treat it? What options have been offered to you?
Well, I've had, there's an ileum where I had a major head removed, and liver is about 50% diseased, I guess. And I don't know, what can you do at this point? And I even wonder, I'm 85 years old, how much do I want to do yet?
I want to look that good when I'm 65. I can't believe you're 85 years old. No, you know what, and now the nurse in me, the old critical care nurse in me says, you're right. That's an absolute valid point. You're 85 years old, what do you want to do?
Take it a day at a time. I enjoy today.
And if that's your goal, take it a day at a time and enjoy each day as it comes?
That's not saying I'm going to die before my time either.
Tell me about the ongoingness of the program. You're getting a certain number of samples. They are going to go from now till infinity, and how the finances part of that work, the insurance, all that stuff.
Sure, I'm glad you asked that. So we've just recently been granted an administrative CPT code by the AMA. That came to us about 3 months ago. And just this past, we got an administrative code. We wanted a Category 1 code, because with a Category 1, we can open up to Medicare, Medicaid, to offer it to more patients and have it covered. Dr. Moblin was in Chicago on Friday. Unfortunately, I haven't heard back from him. They were supposed to give us their decision just this past Friday. But that being said, even with an administrative code, we can start submitting to insurances by the end of the summer. The AMA does it, they do it in time sections. And so once they tell you you've been approved, there's a 3-month waiting period for them to publish it and put it out to the public and put it out to the insurance companies. And then after that 3-month waiting period, we can start submitting charges for our patients for insurance reimbursement.
So you're going to do it for free till that time?
Yeah, no cost to the patient, right?
No cost to the patient.
No, how much does it cost?
Without insurance, it's $750 a test. And that just covers the materials that we use and the time, the scientist's time. Yeah.
Can you talk a little bit more about what exactly you're measuring? Is it concentration of transcripts? And then just in terms of like the scale of 0 to 8, is that like a linear scale?
It is a linear scale, and then we translate it into a percentile.
Okay.
So we like to see our people less than, so if you're a 4, you're actually at a 50% index. So we'd like to see our folks there or less, okay? It's measuring an activity level. So like myself, I'm usually a 2, a 3, a 4, a 4, a 3, a 2, because they draw my blood almost every week. I don't, I'm like, because they're just happy they have a neuroendocrine patient working in the lab. But so it's best represented in a linear fashion through trending. That's really going to tell you. I had a woman the other day in Texas, and her first test came out a 7, and she was like, "Oh, I knew it. I could feel it. I could tell it was back. I knew I was having the symptoms." But I said to her, "This is only one number. Before you push the panic button, you need to send. You're getting 3 free tests. So in another month, I didn't make her wait 3 months. Another month, send us another sample. We'll see what that number is, and then a month after that, send us another sample, so that we can at least begin." And I'm sure you can imagine, even 3 isn't a lot for trending, but at least it's a beginning. And with the expense of the test, it was what my directors had told me to offer the public at this point in time. Did I answer your question?
Yeah, I guess so. So what kind of activity level does age represent?
I'm sorry?
What kind of activity level does age represent then?
Age is not affected. This test is not affected by age.
8.
Oh, I'm sorry. My age. Affected by age. I'm getting old. 8 represents high activity. It's the highest you can get. And
Maserati.
it's a Maserati, and when we see, and we can tell when these people present, they come in and they step in and they're under stress because they're going to get their blood drawn, and they light up like Christmas trees. And then I do a health history with them. They come in, my nice calm office, because I don't want to get people flushing and get them all worked up. But they'll tell you, no, I know it's happening again. And they know they're having increased activity, and they'll say this only started in the past few months. And so I'm not surprised when they come out to be a 6, 7, or an 8. But 8 is as high as it goes. And what we do, because the CGA is actually a different measurement, okay, because the CGA measures tumor secretions. When we have patients where we know they have metastatic disease, but they've been going along, they've been fine, they've been having a great life, a good quality of life, then they come to us and they say, you know what, I want the test because I'm starting to think that it's acting up. And, usually if I treat them, they'll tell me they're having more symptoms. And that's usually the clue. So we'll draw a CGA with the NET test. Again, we don't charge for the CGA either. It's a bundle. You get both done. And sure enough, they'll come out, they'll be an 8. Not all the time. Not all the time do we see elevated CGAs. We've had people full-blown metastatic disease, symptoms, and their CGAs within normal limits. But there have been a few times when they come in, they present and the CGAs are 1,200, 1,500 on a scale of 0 to 19. So between the two tests, then we'll say to them, and we do that because most people, they understand CGA because that's what's been around. So if we have a CGA score to present to them along with their NET test score, then they can put it into, it's easier for them to put it into perspective. Say, oh, okay, now I can see it's a Maserati. Right? Now I know what you're saying.
What is the FDA status at this point?
Molecular testing does not fall under FDA approval.
Or does it?
No, neither does CGA, neither does pancreastatin, neither does 5-HIA.
It's been fully tested for specificity and stuff?
Yes, yeah, I had a slide up earlier, but if you want a copy of the PowerPoint, I had it for specificity and for normal values, different limits. Positive predictive values, I have a slide if you're interested in that.
So you don't get into recommendations for treatment of any kind or anything like that?
Well, what happens is Dr. Moblin is the medical director of the lab, but he does consulting. He has his own consulting business. So we've had folks that have come and had abnormal tests, and they're concerned. They want to know where they should go, what they should do, and then he'll consult with them. And I've had people come in from California, from Texas, from Canada, fly in to see him, and they send the medical records. I give them all the instructions, and they'll sit down with them, and he'll look at their history. He'll look at where they've been, who they've been dealing with, what tests they've had done, because he's a big believer. This is a population that gets over-tested. I mean, some people go for optry scans. I myself, early on, I was going every 3 months for a year, then every 6 months for 2 years, then it was every year. I mean, I am a light bulb at night. So he'll sit down and he'll discuss your individual case, and then between you and he and your physician, he'll work with your physician, your oncologist, or who's ever managing your disease. He picks up the phone and calls them up right away and says, oh, I have Mary Jane here. Mary Jane went through our test, and he'll discuss everything with the physician right on the phone right in front of you and come up with a plan. He has access to people all over the United States and all over Europe. So like I said, 2 years ago, I went for gallium out in Heidelberg, University of Heidelberg. He knew the director of nuclear medicine there. The guy did the test himself on me, which was great. They treat you like you're royalty. And now next week, I'm flying out to Milan. Dr. Bodie, Lisa Bodie's out there. She's a colleague of mine. So she'll be doing my gallium scan in Milan. And some people, for the cost of what some people have gone, and not to Iowa, but to other parts of the United States where they're doing trials, and they've had to dish out $4,000 for a gallium scan. Well, if I'm going to do that, I'm going to go back to Sistine Chapel, right? I might as well make a nice trip out of it. Yes, sir?
When you had this gallium, you had that treatment, did you notice a difference in your serotonin?
Oh, no. The gallium scan is imaging. It's not a therapy. It's imaging, where they inject you with either lutetium-177, depends on the nucleotide that they want to use. They use gallium. 68 gallium it's called. What I did find, it's a good question, is that I had had an Octria scan done probably 6 months prior to my gallium scan. My Octria scan came out ugly, like, you know, these tumors are growing in her liver, the margins are bigger, and, you know, we've got to do something. So that's when I got in touch with Dr. Moblin, and I said, what the heck's going on? So he said, no, I want you to go out and get a gallium, just go. So my sister and I, we had a nice vacation in Germany for 5 days, but the results of that scan showed it's so specific. So the Octria scan, you're flying over New York City, you're flying over Manhattan, and you see all the buildings from the plane. You can see all the buildings in Manhattan. That's the Octria scan. The gallium scan, you can see the green pea that's sitting on the sidewalk on Broadway. That's how more specific the gallium scan is. So it turned out my tumors weren't as big as what the Octria scan was saying, because the Octria scan put shadows around my tumors, and they were misinterpreted as actually being mass when it was just shadowing. So my tumors were much smaller than what they had originally told me through my Octria scan. So I left there with feeling relieved, but it's been 2 years now, so it's time that I go back and get another follow-up. Because I have active disease, so I need to stay on top of it, although nurses and doctors were the worst to follow up on anything. We just don't do it.
As far as using it for diagnostics, is this a better test? My understanding is it's hard to diagnose people that don't have an actual tumor that shows up.
It is, yeah. Unfortunately, we've had folks show up with signs and symptoms, as I've said, and then we really have to work very closely with them because we don't want to mislead them. And sometimes people inadvertently will leave out a portion of their health history that's important for us to know, like, you know, I've been living with Crohn's disease for 15 years. Well, we need to know that. You know, because we'll get an elevated level just on that alone. But if they come in and they say, I'm having symptoms, they can't find anything, but my mother, her father, and her brother all died from carcinoid cancer. And I've heard this. I've had people come up to me, multiple family members expiring from carcinoid. And family members who died from cancer, but they didn't do, it was years back, they had no pathology report, but from what they can remember, that relative, Aunt Jane, always looked flushed. She always had belly aches. She probably had obstruction. I'll give you an example of my own, not to bore you guys with my own family story, but my sister's daughter, my niece, her paternal grandfather, my brother-in-law's father, 91 years old, chronically anemic for 25 years, never went to the doctors, didn't care, ended up in the hospital 2 years ago. Huge bowel obstruction. They rush him to surgery. They come out. He goes up to my sister and her husband. He says, wow, he had a huge tumor in his bowel. It must have been there for years. And my sister said, you gotta be kidding. What was it? And he says, well, it's a really rare form of cancer. It's carcinoid. My sister says, what do you want to know about it? The surgeon just looked at her. So because of that, I had my niece tested because she was having issues with some diarrhea and ulcerative issues. So she came last October, and because she has maternal and paternal carcinoid, we took her blood. She came out to be a 6 on the scale of 0 to 8. But I really felt it was, in my gut, I thought, no, it's really due to her. She's got something going on. So she got scoped. She has ulcers all through her intestines. I mean, she just has a really bad bowel. So she changed her diet. She went on the celiac-free stuff. She's taking Carafate to help heal those ulcers. She came back 6 months later, and she's a 1. She's lost 20 pounds. Her skin has changed. She's well-nourished now. Her hair is showing, because that's the first thing that goes when you're malnourished. She just looks like a whole new person because she changed everything. And rightly so, her score came down. So, but we are seeing a lot of familial, having a lot of people approach me at meetings and saying that family members that died or had it. And the NIH is still carrying on doing their study for familial carcinoid. They're still taking participants from what I understand.
I would think we're a real opportunity here. My mother died of cancer, of carcinoid. And I've got a sister who has these symptoms and had them for a long time. Doctors can't find anything. You could pretty much define whether she has it.
Mm-hmm. If you have it and your mother died from it, I would take your sister's blood. I'd want a sample of her blood.
So that was my question too, generational. I know people wonder, should we test our kids, or if they have, doctors have said, yes, they have IBS, or in the past have said there's issues with that.
Yeah, it's so spurious at this point.
Is this a test to check?
We're hoping to get there. We're hoping to bring this test there, but we haven't had enough time to do that study or to even review the data that we already have. But that's in process. Because we're finding, I'm going back to Connecticut, every time I go back and I say to Dr. Moblin, people want to know. And he says, yes, I understand. He says, but we're being inundated with samples. We're collecting all this data. And just Friday, when I spoke to him from Chicago, he said, and I used to manage the data for the Heart and Vascular Institute at one of the hospitals in Connecticut. I need a data person. I said, well, it's not me. But, so we're going to look into getting a data person who will lead us, will give us an idea as to the capacity of this test, even more so than what we already know it to be able to do. But yeah, people are looking for that. I had my daughter tested just because she's my daughter and I could have her tested. But we're getting more and more requests of that nature.
Or would it be worth to check grandma while we have the opportunity, or?
Well, we usually, if the symptoms are there, then we'll take the blood. If the symptoms are there, we'll do it.
But to get somebody to do it and to see if insurance will cover it is kind of a tricky thing.
Yeah, it's a tricky point. Yeah, because if they're not definitively diagnosed, or because we're not promoting this as a diagnostic, first mainline diagnostic. Right now, this is why I'm coming out and speaking to people who already have the disease, because we know we can find your signature, your NET signature circulating in your blood. And based on that, we can tell you if your therapy is working or if it's not, or if your disease is stable or it's starting to take off. But as far as taking Joe Average off the street and doing a blood test to see if he's got it, because again, remember, everybody has neuroendocrine cells. Ours just happen to be really crazy and very proliferative.
How much resistance do insurers give you after they've heard your presentation?
I have not.
Decide that you're looking for what you're trying to find and you found it.
Well, the thing about insurers is, first you have to get a CP code for them to even talk to you, as you know. So we just got that. Then you hire a person to go in and to talk with the insurance people. And they talk savvy. Right? How much can we get reimbursed on this test? What's the value in this test? So I haven't presented to them, so I haven't gotten any pushback from insurance people, because we were waiting for our CPT code to come in first.
So do you have any concerns about that? That you actually found what you were looking for? Surprise, surprise.
I know, yeah. No, I think there'll be reimbursement. How much, I don't know. If the AMA gives us their blessing, which is essentially what they do with the CPT code, then the insurance companies are on board. However, just how much on board? And that's where they'll get you, and how much they're willing to reimburse you. Or they'll set up strict parameters. We're only going to reimburse the patient who has X, Y, and Z, definitively diagnosed, has metastatic disease. They can create all the, they can make up the list saying, these are the only people that we're going to reimburse for this test. This is what we want to see. But we're going to have negotiators working with the insurance companies to hopefully see things our way.
So the order would still have to come from your doctor to then go through the insurance?
Yes. Yep, the order for the test has to come through your doctor.
You mean though by this test, you can tell for sure if they've got carcinoid?
We're not using it at people coming in off the street and saying, can you tell me if I have it? We can give it to people who have had carcinoid, who've been told they have a surgical cure. We can tell them whether or not they've really had a surgical cure or not. And 9 times out of 10, there's no surgical cure. It's still there. It may be very stable, very subtle, but it's still there. We've even had people show up with a liver full of tumors, and they can't find a primary. So we'll monitor them, and then based on our test, they'll decide, should I get a hepatic embolization, should I get a chemoembolization? I mean, that's really something, some oncologists believe in chemotherapy with carcinoid, other oncologists believe that chemo really doesn't have any effect on the disease, but that's a matter of personal choice for the physicians and for the patients.
How would we be able to access the test now?
If you see, that's a really good question. So people call me up around the country. It varies from, I've had people walk into a lab with no physician's order and say, I need blood drawn. Here's the protocol. Can you do this? Sure. And they do it. I've never heard of that. Every lab I've gone into, you've had to have a doctor's requisition in your hand and go in. So what we usually recommend is, A, if your physician is not aware of the test, because a lot of people, they'll deal with just their primary, not an oncologist, it's their general practitioner who might not be aware of the test. I always encourage them to contact me or to contact Dr. Moblin if they want to learn more about the test themselves before they go ordering it. And then what the physician will order, he'll just, on the sheet, there's a spot for molecular blood tests. And he checks that off. You take that to your lab. The lab draws the blood. Now, here's another thing that gets tricky. Some labs, they have the styrofoam and the cardboard container that it needs to go with. They have the dry ice, and they'll do all of that. Some patients that have called me up, they hadn't worried about a thing. Other patients, the labs don't do it. So in the protocol, it's very specific. It tells you what size styrofoam box to get, how much dry ice to buy, and then it's got to go into a cardboard box because FedEx won't ship just styrofoam. And then it tells you how to label the box. So the instructions are all there. So depending on where you're at and what lab you get hooked up with, you're either going to find a lab that's going to do it all for you and ship it off, and it's got to be overnight because that blood has got to be frozen. They're either going to do it, or they're going to tell you, we'll draw your blood, but you have to bring all the goodies so that we can pack it and ship it off.
Do you know if LabCorp or Quest will be able to do that?
LabCorp does do it. I don't know about Quest, but LabCorp, I'm hearing from a lot of patients, LabCorp does do it. And if they're not going to be able to ship it out overnight, like you're watching them and they're packing it up in the dry ice and then it ends up on the counter, you take it and ship it through FedEx. Because otherwise it's going to sit there overnight and it's not going to get shipped out till the next morning, and then we're going to get it on day 2. And we end up getting a drippy bag with warm blood. And then we've got to call them up and say, got to do it again. You didn't follow the protocol. The protocol's pretty easy.
Is LabCorp Quest in town?
Pardon me?
Are they in town here?
There's one LabCorp in Minnesota, and it's in Edina, right next to Fairview Southdale. And there's also a Quest lab there too. But I've had a little problem with LabCorp because the only way you can get to them is to do it on the computer. You make an appointment on the computer, and then there's a little box where you can write your message in. And the last time I wanted, I think it was a Pancreastatin from ISI, and I get there, and I told them they needed the Z tubes, and they know that. And I got there, and they didn't have the Z tubes. And he said, well, we'll take your name and call you when they come in. I'm still waiting to hear. This was in January.
Oh, God.
Wow.
They're overwhelmed. I managed to get a human there one time through another connection. And they're just swamped all day.
Wow.
Yeah, because they're doing a lot of drug testing for companies.
Yeah, they don't have enough
But those
people.
are the walk-ins, when you have an appointment, they need to honor that appointment and do what they're supposed to do.
If they'd like to be in business, but they're so busy they don't.
They don't
see
care.
it from a
Yeah.
customer
Yeah, they
relations
don't.
standpoint.
Because they figure, so what's one out of
You lose one, you
Yeah.
get 50 more
waiting behind them?
next
Yeah.
half hour.
Yeah, that's too bad. Yeah, I know the folks in Washington, D.C., they can't find any lab to do them. Some of them, their physicians have done it in their office. The physicians are behind it, and they'll say, look, we'll do this for you. We'll draw your blood, and we'll help you ship it off. But, again. So part of our business plan is to figure out how we can collaborate with physicians in specific areas around the country who are willing to support carcinoid patients and ordering the tests for them and working with a local lab to be able to make this happen. Because we're in Connecticut, we realize not everybody can come, we're just outside of New Haven, not everybody can come to Connecticut. And we have to make the test accessible. It's one thing for me to travel all over the country and tell everybody about it. It's another thing if folks can't get the blood drawn and get it shipped. So we're looking into that now.
Have you had any contact with Mayo?
Mayo, we use Mayo to validate when we get new kits in for CGA, we send them samples. From that perspective, we collaborate with them, but it's not for the NETest. We haven't gotten that far yet. We're just now on the cusp of setting up partnerships. Again, Dr. Warner at Mount Sinai has been sending us samples. We were in partnership with Ed Moblin out in California, but he's now moved on to Kentucky, I think it is. And so it's been difficult to establish collaboration here in the States, for one reason or another.
But you think Odorizio will be doing this?
He doesn't do the test, but I mean, he knows about the test. So I imagine if a patient asked him, "Can you please order me, get this blood drawn for me so I can send it off to Connecticut?" I'd be curious to see why he would say no.
I mean, there's a lot of people here that
Yeah.
go to see Odo.
Yeah, I would be, because again, he's been at all, he's seen the presentations, he knows the science, he's seen the papers. I can't speak for him. I talked to him on the phone this past fall, like I said, and we chatted a little bit, but, the proof, I guess, would be in the pudding when somebody goes to see him and says, "Will you draw my blood and send it off to Wren?" Yeah, find out about it, see if he'll do it. And if that's the case, again, let me know, because you have the health history form already in front of you. So if you decide that you do want to, you're able to find somebody to draw your blood, you're going to send a sample, a couple of things. I'll send you out, I'll email you a copy of the health form if you don't already have it, because I need your health history, and that's our actual requisition. I'll send you a copy of our HIPAA, where we protect your patient identification, privacy, your medical information. I'll send you a consent form saying that we can take the specimen and run it. Authorization to release information to a physician or a spouse, whoever you want, to allow me to speak to. And then I'll send you the lab protocol. And the lab protocol, it's like 10 steps, very easy for a lab technician to follow. And then attached to that, it's like another 3 sheets on how to package the blood. So I can send you all of that. And that's the health history sheet. And if you're having a hard time filling that out and you're going to be sending me a sample, call me up, I'll go over it with you. We can review it together. Sometimes when you have somebody stirring things up, you can remember stuff.
So you've got a business card?
I do, I'll pass them out now. Any other questions? You guys had some really good questions.
How about if we move the lab to India?
That's not happening.
Oh.
Now,
$7.50.
we may be opening up a satellite in Australia because we have found interest, because the highest concentration of MEN1 patients are in Tasmania. Because of 2 families that settled there in the 1800s, they were carrying the gene, and then they intermarried, and now they've got through the decades, they've got a huge population of NEN patients there. So they're working with us. They're interested in our tests.
That's interesting, because I've been in contact with some Tasmanian patients. They don't get the best care in the world either. Huh.
Because not all of them can afford to get on the ferry and go over to Melbourne.
Yeah.
It's a trip for them. They can't afford it. But yeah, they have the highest concentration. It's really interesting. All right, I have business cards for everybody. And if there's something that patients have said, well, let's just wait and see what's going on. And you can't wait and see when you have neuroendocrine disease. It's just not appropriate. And this test is the antithesis of wait and see, because this test is going to tell you well in advance what's going on. There's no waiting. It's like, this is what's happening.